I'm Carla Pecoraro.
I'm Mel Acreman.
And I'm Anne Woolfield, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things ONG. I feel like it's been a while since we've had an episode of Evidence with Anne. Time to get back into it. Our Evidence with Anne episodes are where we take the RANZCOG landmark trials and transform long, complicated journal articles into hopefully something more manageable. Today we're going to go through the gynaecology-oncology landmark trials. If you've missed some of our earlier episodes, I'll explain what we mean by landmark trials. RANZCOG has a list of landmark papers on their website, which are all examinable, and that's what we're going to go through. There are two landmark trials relating to gynaecology-oncology. The first is the PLCO study, which evaluates the effectiveness of screening for ovarian cancer, and the second is the LACE trial, which investigates the approach to hysterectomy in those with stage 1 endometrial cancer.
So let's start with the PLCO study, or the full name, the effect of screening on ovarian cancer mortality, the prostate, lung, colorectal and ovarian PLCO cancer screening RCT. It was published by Byers et al. In the JAMA in 2011.
The aim was to determine the effect of specific ovarian cancer tests on ovarian cancer mortality. It was a multi-centre, randomised controlled trial across 10 centres over the USA between November 1993 and 2001.
I'm so impressed. They were so patient to keep the trial going for 18 years. First, 8 years just to randomise patients, and then another 10 years for all of the follow-up. Over 78,000 women aged between 55 to 74 years old were randomised to either annual screening with CA125 and transvaginal ultrasound or routine care. The CA125 was continued for 6 years, whereas the transvaginal ultrasound was continued for 4 years. The follow-up was for a maximum of 13 years.
Were there any specific inclusion or exclusion criteria?
Luckily, these criteria are pretty straightforward. The inclusion criteria included no previous diagnosis of lung, colorectal, or ovarian cancer. Those with the previous bilateral oophorectomy were also excluded. The primary outcome was mortality from ovarian cancer. This included primary peritoneal and fallopian tube cancer. Secondary outcomes included ovarian cancer incidence and complications associated with screening examinations and diagnostic procedures.
Repetition.
Repetition.
Okay, that's enough. The PLCO trial is called The Effect of Screening on Ovarian Cancer Mortality, the Prostate, Lung, Colorectal and Ovarian PLCO Cancer Screening RCT. It was published by Byers et al. In 2011 in the JAMA. It was a multi-centre, randomised controlled trial involving 10 centres across the United States.
It randomised over 78,000 women aged between 55 to 74 years old to either annual screening with CA125 and transvaginal ultrasound or routine care. The follow-up was for a maximum of 13 years. They excluded those with the previous bilateral oophorectomy and included those who had no previous diagnosis of lung, colorectal or ovarian cancer.
The primary outcome was mortality from ovarian cancer, including primary peritoneal and fallopian tube cancer. And the secondary outcomes included ovarian cancer incidence and complications associated with screening examinations and diagnostic procedures.
The results found that the diagnosis of ovarian cancer was higher in the screening group with a relative risk of 2.21 and a 95% confidence interval of 0.99 to 1.48.
Okay, but was the mortality between the groups any different?
Unfortunately, no. The mortality difference in those screened versus those unscreened had a relative risk of 1.18, but was not significant with a 95% confidence interval of 0.82 to 1.71.
Of those who underwent surgery for false positive investigations, 15% had serious complications. In this study, borderline tumours were also considered to be a false positive.
So overall, there was no reduction in mortality from ovarian cancer with screening, and the diagnostic evaluation after a false positive test was associated with serious complications.
There are a few features of this article I wanted to bring to your attention. First, the study design was a randomized control trial, had a large sample size. These are some huge strengths. There was an independent data monitoring committee, which was great. They advised to stop the study early and report the results. Another strength of this study was that the demographics between the two groups were virtually identical. In contrast, the follow-up was only for 13 years. The CA125 was for 6 years and the transvaginal ultrasound for 4 years. But then I guess the study was stopped because the Independent Data Monitoring Committee advised to stop the study. The study was not powered to detect a small effect size, although I can't imagine how many patients you would need to enroll if you were going to detect a really small effect.
So, in summary, screening for ovarian cancer with a CA125 and a transvaginal pelvic ultrasound increases the diagnosis of ovarian cancer, but does not reduce the mortality associated with ovarian cancer. In fact, there are some serious complications associated with the diagnostic evaluation after a false positive test. So, as per the PLCO study, no screening is indicated for ovarian cancer. Next trial. The next gynaecology landmark trial is about the route of hysterectomy for those with stage 1 endometrial cancer. Mel, take it away.
All right, so the full name is Effect of Total Laparoscopic Hysterectomy versus Total Abdominal Hysterectomy on Disease-Free Survival among Women with Stage 1 Endometrial Cancer, a randomized control trial. It was otherwise known as the LACE trial and was published by Janda et al. In the JAMA in 2017.
The aim of the LACE trial was to investigate whether a TLH is equivalent to a TAH in women with treatment-naive endometrial cancer. It was a multi-centre randomised control trial conducted in 20 centres across Australia, New Zealand and Hong Kong.
The participants included 760 women with treatment-naive stage 1 endometrial cancer. They were randomized to a total abdominal hysterectomy or a total laparoscopic hysterectomy, with 353 and 407 in each group respectively. The randomization was stratified by treatment center, grade, and history of cancer.
Patients were pretty much excluded if they didn't meet those criteria. These included those with stages 2 to 4, bulky lymph nodes on imaging, a uterine size of more than 10 weeks gestation, or if the histological subtype was anything other than endometrioid. What were the outcomes?
The primary outcome was disease-free survival. Secondary outcomes were disease recurrence, patterns of recurrence, overall survival, cost-effectiveness, and morbidity outcomes such as pain, analgesia use, and quality of life.
So, summary time. Let's talk about the who, what, when, where, why, and how. So, the LACE trial, otherwise called Effect of Total Laparoscopic Hysterectomy versus Total Abdominal Hysterectomy on Disease-Free Survival among Women with Stage 1 Endometrial Cancer, a randomized controlled trial. It was published by Janda et al. In the JAMA in 2017.
It was a multi-centre randomised control trial conducted in Australia and New Zealand. It randomised 760 women with stage 1 endometrial cancer to either TLH or TAH. The primary outcome was disease-free survival.
How long did they follow up people for?
They were followed up for a median of 4.5 years. 89% of the participants completed the trial, which I thought was actually pretty good.
I'm guessing from what we discussed in our last episode that there was no difference in the outcome?
You guessed it. The disease-free survival was 81.3% in the total abdominal hysterectomy group and 81.6% in the total laparoscopic hysterectomy group. There was no statistical difference between the two groups for recurrence or overall survival. This meets the criteria for equivalence.
Amazing. So TLH it is. So much better for recovery for these patients.
Let's do one final summary for these two trials. The PLCO trial is called the Effect of Screening on Ovarian Cancer Mortality, the Prostate, Lung, Colorectal and Ovarian, PLCO, Cancer Screening RCT. It was published by Byers et al. In 2011 in the JAMA. It was a multi-centre randomised control trial involving 10 centres across the USA. It randomised over 78,000 women aged between 55 to 74 years old to either annual screening with CA125 and transvaginal ultrasound or routine care. The follow-up was for a maximum of 13 years. They excluded those with a previous bilateral oophorectomy and included those who had no previous diagnosis of lung, colorectal, or ovarian cancer.
The primary outcome was mortality from ovarian cancer, including primary peritoneal and fallopian tube, and the secondary outcomes included ovarian cancer incidence and complications associated with screening examinations and diagnostic procedures. The results showed that the diagnosis of ovarian cancer was higher in the screening group, with a relative risk of 2.21, and a 95% confidence interval of 0.99 to 1.48. But there was no difference in mortality in those screened versus unscreened. And of those who underwent surgery for false positive investigations, 15% had serious complications.
The LACE trial, otherwise called Effective Total Laparoscopic Hysterectomy versus Total Abdominal Hysterectomy on disease-free survival among women with stage 1 endometrial cancer, a randomized control trial. It was published by Janda et al. In the JAMA in 2017. The LACE trial was a multi-centre randomized control trial conducted in Australia and New Zealand. It randomized 760 women with stage 1 endometrial cancer to either total laparoscopic hysterectomy or total abdominal hysterectomy, and the primary outcome was disease-free survival. 89% of the participants completed the trial, and there was no difference in disease-free survival between the TLH and TAH group. There was equivalence between the two procedures.
Thanks for listening to this week's episode of Evidence with Anne on the Uterine Sound podcast. You can find our summary slides on Instagram later in the week. And if you have any comments, feedback, or want to fact check us, please reach out to us at our email at theuterinesound@gmail.com and check us out on Instagram and Facebook at The Uterine Sound.